Welcome to the AUGS Global Surgery Packages webinar. This webinar is to help you, AUGS members in the 9 affected states, to know what is required of you regarding data reporting on your Medicare claims for post-operative care provided during the global surgical period. This webinar content is being provided to you by the AUGS Coding Committee here on June 29, 2017. My name is Jill Rathbun, and I'm a health policy consultant to the AUGS Coding Committee, and I'm excited to be able to share this information with you today. What are we going to talk about? Well, our agenda for this time together is first, how global surgery reporting is changing. Second, what procedures will require you to report your post-operative visits separately on the Medicare claim? Who is required to report? When are these new requirements taking effect? And then we have a few frequently asked questions, and then we're going to tell you how to ask your questions of the AUGS Coding Committee. So first, a couple acronyms that you're going to hear during this webinar today. One is the concept of CPT. This is current procedural terminology. These are the codes that you report. E&M, that stands for evaluation and management. Some people think of it as office visits. HCPCS, that's another coding system that many of those codes have alpha character plus 4 numbers. Then there's MACRA, the Medicare Access and CHIP Reauthorization Program Act, and this is the legislation that is the cause of the global surgical package reporting change. And then TIN is your tax identification number for your practice and how you might be submitting your claims to CMS under the TIN. So how is global surgical reporting changing? Well, effective for procedures furnished on or after July 1st. So we're coming up very quickly to July 1st. So any surgeries that you perform on or after July 1st that are on the list of the 293 surgical procedures with 10 or 90-day global periods, you will have to separately report all post-operative visits for that patient. We'll tell you in a minute which procedures we think will be impacting AUGS members out of the list of 293. Also, it's not all practitioners, and only certain practitioners will have to report, and we're going to talk about which states are impacted and what size of practice you have to be impacted. Then we're going to talk a little bit about how you're going to report. You're going to be reporting the post-operative visits using the current CPT code 99024. Right now, you probably have never been reporting a post-operative visit because it's all included in the global surgical package. So what is a post-operative visit for the purpose of separately reporting it? So these are follow-up services performed during the post-operative period for reasons related to the original procedure. So if it's a 90-day global package, it would be a post-operative period starting at the end of surgery all the way to the end of 90 days. If it's a 10-day period, it would be all the way to 10 days. So it's all the visits that you are performing during that time. These visits can occur in all sites of care, including but not limited to an ICU, an inpatient med-surg, outpatient clinic, skilled nursing facility, your office. So every time you see that patient during the time either of 90 days or 10 days, it would be those post-operative visits. Also, some relevant telehealth visits could also be needing to be reported because the patient is located at an eligible originating site. So you'll see in some of the states that got selected because of the rural nature of the state, a telehealth visit may be appropriate to be reporting as a post-operative visit. So which surgical procedures are included in this new requirement? Well, as I mentioned, it's not all surgical procedures. It's 293 surgical procedures that were selected. CMS selected these procedures based on their 2014 Medicare claims data. And what they did is these are procedures that are performed by more than 100 practitioners in 2014, and they were performed more than 10,000 times, or they had allowed charges exceeding $10 million. So that's how these 293 codes were selected. Medicare staff also took into account if the CPT codes had changed, and they accounted for those changes between 2014 and 2017. Also, procedure codes subject to reporting will be updated yearly and published prior to the beginning of the reporting year. So we are anticipating a new proposed physician fee schedule for 2018 to be out here in another week to 2 weeks, and we anticipate there will be a discussion about what codes will be reported in 2018 versus the last 6 months of 2017. So we will be providing you with updated information probably in November and December. So here is the list of 293 codes. As you can see, it looks like a really jumbled, crazy computer screen. It's not. It's a long list of CPT codes. So we've highlighted in yellow 3 codes that we know for sure AUGS members perform. One is CPT code 57240. That's, of course, the anterior repair code. 57288, sling code. 58571, laparoscopic hysterectomy code for uterus under 250 grams. Now, there may be other codes in this list that you in your practice do occasionally perform. So you would have to report the post-operative visits on those codes. But predominantly, it will be these 3 codes that will be impacted in your practice. Now, you're going to say to me, Jill, I don't always do a 57240 by itself. Many times I do that with another procedure. Well, yes. However, the fact that you did a 57240 at all means that that patient's case, that 90-day global period for that patient, will be part of this reporting program, and you will have to report the post-operative visits for that patient. So if any of these codes are on the claim in any shape, way, or form, that will kick that patient into the data reporting requirement. So you have to think about those combination procedures, not just procedures where you're only doing one surgery. So who is required to report? Well, it's billing practitioners, so it's not just physicians. It's physicians and non-physician practitioners. So if your nurse practitioners or your physician assistants are also providing post-operative care, you would be reporting their post-operative care visits that they perform. You have to practice in one of the 9 states that was randomly selected by the Centers for Medicare and Medicaid Services, otherwise known as CMS. And you have to be in a practice that has a group of 10 or more practitioners, and part of a practice that provides global surgical services under one of the required procedure codes. So who are these 9 states? And how does CMS define a practice so you know whether you have 10 or more practitioners, including all physicians, all nurse practitioners, all physician assistants? So first of all, let's look at the 9 states. Well, Florida, a lot of physicians in Florida. Kentucky, not as many physicians. Louisiana, Nevada, New Jersey, North Dakota, again, that may be where some of the telehealth visits would come into play. Ohio, Oregon, and Rhode Island. So these states were randomly selected to be representative with respect to size of states in regards to their number of Medicare beneficiaries and to look at all parts of the country, so geographic diversity. So if you practice in one of these states, you need to get a plan in place quickly to start reporting all the post-operative visits on all your surgeries that were performed starting on July 1st. So let's talk about how we count to 10, so to speak, in regards to knowing whether your practice is actually going to meet the threshold in regards to number of practitioners. So what CMS says is practitioners who practice in at least one group of 10 or more practitioners are required to report all post-operative services provided in all groups. So you have to think about how many practitioners are in my group. And even if I'm in multiple locations, and even if those locations are not all in the same state, I'm thinking about New Jersey versus going across the river to New York. Well, if you have at least 10 or more practitioners in your New Jersey location, then all your services will be required to be post-operative visits reported, even the ones you perform in New York. So how is a practice defined? This is where this thing that we talked about earlier, the tax identification number, plays a role. So practices are defined as a group whose business or financial operations, clinical facilities, records, or personnel are shared by 2 or more practitioners, even if it's not at the same physical address. So another way to look at it is, are you all billing Medicare together under the same common tax identification number because you're sharing business or financial operations, maybe you're sharing electronic health records, maybe you're sharing office space. So even if you're in a multi-specialty group practice, if you're in a big academic faculty practice plan, etc., you're probably going to meet the threshold of 10 practitioners fairly easily. But even if you're in a multi-specialty GYN practice, where it's generalist, urogynecologist, GYN oncologist, etc., you might easily make the 10. So again, you have to understand how you're connected with others and then count up your number of practitioners to 10. So how do you report these visits? Well, again, as we mentioned before, you will report them on the usual 1500 Medicare claim form that you use to bill all your services to Medicare. So it's going to have your practitioner information, the beneficiary information, the date of service. You don't have to link the CPT code 99024 to the original surgical procedure, but you are going to have to know that that patient had originally one of the surgeries that was on the list of 293 codes. So you are going to have to look back and say, oh, this is a patient who had a sling procedure. This is a patient that had a hysterectomy, etc. And then when you see them for their post-operative visits, you're going to have to bill 99024. You don't have to put any time units on it or modifiers. And practitioners can submit multiple 99024s on the same line as long as the claim includes the applicable range of dates of service. So let's say you see a patient over the 90-day period 4 times. You don't put the claim in until the end of the 90-day period. You could put all 4 of those 99210s on the same claim. You just have to make sure you have the beginning and the end dates correct. Also, other Medicare billing requirements will be needed to be adhered to, and teaching physicians will have to follow the usual CMS policies for appropriate billing in a teaching environment, knowing those rules. And again, you'll still use CPT code 99024, but you will be in a teaching environment, so some of the modifiers, undergraduate medical education, the GC or the GE, may apply. And you'll need to check those rules at your institution. So as I mentioned, this reporting takes effect pretty quick now, actually next week. So any post-operative visits that are being performed for surgeries that were performed on or after July 1st need to get reported. Anybody could have started reporting after January 1st, and maybe some of your big academic practices that AUGS members are practicing with did, but most of them did not. And the reality is most people don't even know yet that this is happening. So again, you can spread the word within your group if you're in one of the states that needs to report, and you can check your electronic health records and your billing software ASAP to make sure you can get 99024 on the claim, and make sure that you can identify the patients from their original surgery easily, and track all their post-operative visits and get them on. Because eventually this data will be used to decide how to set payment rates for global surgical packages surgeries in the future, and we want to be sure that every single post-operative visit gets collected and gets reported, because we don't want physicians years from now, if these codes have to get redone, to not get paid for work that you are providing. So it's really important that you document every post-operative visit in the inpatient setting when the patient's there, in the outpatient setting in the hospital when the patient's there before they go home. Everything that you're doing needs to be documented if it's a post-operative visit. So CMS has put together some frequently asked questions that they've already been asked on the webinar they did on April 25th. So here are some of their pre-done answers. What if the post-operative care is transferred to another practitioner? I.e., what if a patient comes to see you to do the surgery and then they go home to another state and you transfer that care to another practitioner in that state? So reporting is required when a post-operative visit is furnished by another practitioner in the same practice or the same tax identification number. So in this instance, the patient's probably not physically going home to another state. It's just probably that they're being seen by one of your partners or a nurse practitioner or a PA in your practice. So all those post-operative visits still need to be reported. This is a new reporting requirement that does not change what care is included under the global payment. If another practitioner in the TIN provides care unrelated to the procedure, they should continue to bill using the relevant office visit / evaluation and management codes or other HCPCS codes. So again, these are post-operative visits related to the condition that caused the original first surgery with the global surgical package. If the patient comes in for another wholly unrelated clinical issue that you or your partners or your fellow practitioners are taking care of, they need to, of course, bill the appropriate office visit and or any other codes that that patient receives services. For some procedures, it's common for the practitioner who performs the procedure to transfer post-operative care to another practitioner. That's not very often the case, in my opinion, with OGS members, with urogynecologists, versus maybe some of the other surgical specialties, like here CMS gives the example of ophthalmology. We're more taking care of our patient for all their condition, not doing the surgery and then transferring them to a different specialty. But if that were to happen, you have to follow the appropriate coding rules for that. The practitioner who assumes post-operative care should submit the 99024 claims for the post-operative visits if they meet other sampling requirements, i.e., they're in one of the 9 states and their practice includes 10 or more practitioners. So here's another question that CMS has been receiving. What if I furnish other services to the same patient on the same day? Again, all post-operative visits covered by the global period must be reported. So again, if it's related to the original issue of the global period, i.e. for the surgery that is part of the list of 293, it would need to be reported. If you're furnishing multiple post-operative visits to the same patient on the same day, only report 99024 once, same as regular office visit E&M reporting rules. Any services not covered by the global period, i.e. separate and distinct services for different conditions, etc., are subject to normal billing rules. So not unlike common billing rules today for global surgical package reporting in regards to what is or is not included in the package. You would follow those same normal billing rules. What if I practice in 2 practices, so with 2 different groups or 2 different situations, but only one meets the size threshold, i.e. the 10 or more practitioners? CMS says you are still required to report. Practitioners are eligible if they have relationships with at least one group with 10 or more practitioners. So you would have to report. Practitioners in this situation must report all eligible post-operative visits, no matter which practice is associated with the procedure. So that's pretty clear. If you're in 2 practices and one meets the threshold, you're in and you're reporting. Does my alternative employment model affect the practice size threshold? Practitioner count should include all billing physicians and non-physician practitioners, regardless of whether they are furnishing services under an employment, a partnership, or an independent contractor model under which they practice as a group. And again, it goes back to do they share a facility? Do you share billing and financial resources, etc.? But again, continue to bill Medicare independently instead of reassigning your benefits. So again, this is goes back to how is your practice put together? Are you all under a tax identification number? Are you sharing financial resources, facility resources, clinical resources, etc.? And then do you have the 10 or more practitioners? How do we account for part-time or short-term practitioners and staff fluctuation when we're looking at how to count to the 10 or more? When practitioners provide services in multiple settings, the count may be adjusted to reflect the estimated proportion of time spent in the group practice or other setting. Generally, practitioners in short-term situations would not be included in the count. Practices should determine their eligibility based on the typical number of practitioners that work in the practice in the first 6 months of 2017. So for whatever reason, your practice had a number of people change their employment status with the practice or leave the practice for the back half of 2017, you really want to look at the first half of 2017 and put together your counts in regards to whether you're meeting the threshold of 10 or more. Is reporting also required for Medicare Advantage and VA patients? VA meaning Veterans Affairs patients. So reporting is only required for traditional fee-for-service Medicare patients, right? So if you have seen patients for which they are getting their Medicare coverage through a Medicare Advantage plan, you would not be reporting the global post-operative visits on those patients. This is for people who you are billing the Medicare contractor for your state directly for traditional fee-for-service Medicare patients. So we need to be cognizant of that because more of our patients do have Medicare Advantage. Also, a number of patients, although not as many women, do get care through the VA healthcare system. Again, this is only for Medicare fee-for-service patients. Are CMS contractors prepared to accept 99024? Can a small charge be put on the claim? So this is something we've been very concerned about is will CMS be ready? So will the folks who adjudicate your claims and check them for completeness and correctness, so the folks who work with, Noridian, Novitas, CGS, et cetera, all the Medicare contractors, are they going to be ready? So CMS says yes, they're going to make sure they're ready. It's possible if your software requires you to put like a penny on the claim in the charge box to allow the software to process the 99024, that will be fine. CMS says here that they're working to make sure that those claims will get through. So again, we hope, knock on wood, that CMS is also going to be ready for any post-operative visits post July 1st. So we're going to take them at their word at the moment, but again, we're going to encourage all OGS members who are in the 9 states in a practice with 10 or more to please let us know as soon as possible if you are having trouble getting your claims to process with the 99024 on the claim. So in summary, select practitioners are required to report post-operative visits furnished during global periods starting on or after July 1, 2017. Reporting requirements apply to practitioners and practices of 10 or more practitioners, with practitioners being physicians and nurse practitioners, PAs, et cetera, who bill Medicare. And there's a list of 9 randomly selected states. So you practice in one of those states. You will be required to report all post-operative visits for the 293 procedures that were selected, of which we believe there are approximately 3 surgical procedures that OGS members perform and that they will need to be reporting all the post-operative visits on those patients. You'll be reporting the visits using 99024. And if anyone else would like to report or did start to report prior to July 1st, 2017, that's great. But it was optional, and you shouldn't be concerned if you didn't do it. So that's sort of the situation at hand with global surgical package reporting. OGS definitely wants to answer all questions from the members on this, particularly as those in the 9 states begin to start reporting your 99024. Again, I must stress how important it is to do this post-operative visit reporting. If we do not do the reporting, definitely CMS is going to use this data to reevaluate whether these surgical procedures should have included payment, work payment, practice expense payment, malpractice payment to physicians if physicians aren't actually performing these post-operative visits that are already currently in the codes and being paid for. So we really need every OGS member in the 9 states to take this seriously, to report every post-operative visit, every visit in the hospital before the patient is discharged, every visit when they come and see you in your office, every visit to every practitioner, not just yourself, but your NP, your PA, your partners, et cetera, and get all of those reported. It may be very possible that AUGS members are doing more visits than what's currently included in the payment for the codes, and that's as important to know as anything else. So here's the web link on the AUGS website to ask us any questions you have on this. Also, we have materials on this link, a fact sheet that gives a lot of the information from today, a fact sheet from the Centers for Medicare and Medicaid Services of their frequently asked questions, as well as a copy of this webinar with the audio and the slides that you're welcome to use at your institution, play during grand rounds, play during department visits and meetings, etc. So again, we greatly appreciate you taking the time to go through this recording with us, to learn, to ask questions, and to read the materials on the AUGS website. Again, thank you so much, and we look forward to working with you as you report your post-operative visits during the global surgical period. Thank you very much, and have a great day.